All right, today we're putting on our detective hats. We're diving into a real high-stakes investigation, one where every clue matters. Our mission? To crack the case of acute kidney injury.
Okay, let's get right into it. Here's the scenario. You've got a patient. They're confused and they haven't passed any urine all day. This is a classic, textbook setup. So as the lead detective on this case, where do you even begin? What's your first move?
You know, in any kidney case, you've got to start with the simplest explanation first. Could there just be a blockage? A literal plumbing problem somewhere downstream? In medical jargon, we call this postrenal AKI, but really, that's all it is, a backup in the system.
So, our investigation kicks off by ruling out the usual suspects. In older guys, an enlarged prostate, or BPH, is a super common culprit. But we also have to think about kidney stones, a potential tumor somewhere, or even scarring in the tubes, which you might see with something like scleroderma. The easiest way to check? Just grab an ultrasound and take a peek, see if anything's backed up.
All right, so let's say the ultrasound comes back clean. No blockage. Now our investigation gets a bit more complex. We have to start listening to the body itself. What kind of SOS signals is it sending out? Because trust me, it's definitely trying to tell us something is seriously wrong.
And this is where it gets really interesting. You see all these different symptoms, the nausea, the confusion, even that weird flapping hand tremor we call asterixis, they all point back to the same villain, a buildup of waste products in the blood. We call that uremia, and it's basically poisoning the system from the inside out, hitting everything from the stomach to the brain.
And out of all those clues, this is the one that sets off all the alarm bells: chest pain. If your patient mentions chest pain, you have to immediately think uremic pericarditis. It means those same nasty toxins are now irritating the lining around the heart. This is not just a symptom, folks. This is a 5-alarm fire, a true medical emergency.
Okay, so we've interviewed our patient and we've gathered all the physical clues. Now it's time to take our evidence to the lab for some real forensic analysis. This is where we get the hard data that's going to help us build our case.
And that blood work tells a pretty clear story. The waste products, BUN and creatinine, are sky high. That confirms the kidneys aren't filtering the junk out. Potassium levels are climbing, which is super dangerous for the heart. And then there's this thing called a high anion gap metabolic acidosis. I know, it's a mouthful, but all it really means is the body is becoming dangerously acidic because the kidneys just can't do their job of clearing that acid out.
So, we've got all this evidence piling up. We know for sure the kidneys are failing. But here's the million-dollar question: why? Is it just a problem with blood flow to the kidney, a prerenal issue? Or is the kidney's own internal machinery, the little filters inside, actually broken? That's the core mystery we have to solve. And to answer that question, we need to analyze our most important piece of evidence: the urine sample. You see, the blood tells us that there's a problem, but the urine is about to tell us why. It's going to crack this case wide open.
Okay, look at this. This table is everything. In a prerenal state, the kidney's tubes are healthy. They're just starved for blood, so they go into survival mode. They grab onto every last bit of sodium and water they can, making the urine super concentrated with low sodium. But if the tubules themselves are actually damaged, what we call acute tubular necrosis, or ATN, well, they can't do that. They're broken, so they just leak sodium right into the urine, which becomes all watery and dilute. It's a night and day difference. And then you get this. This is the moment every detective dreams of: the smoking gun. If the lab calls and says they see muddy brown granular casts, that's it. Case closed. These are literally chunks of dead kidney cells floating in the urine. It's the microscopic proof, the fingerprints all over the weapon. There's just no arguing with that. And if you need a number to absolutely seal the deal, here it is. We look at something called the FeNA. It's basically the percentage of sodium that the kidney is letting spill out. If that number is over 1%, it confirms it. The broken tubules are leaking. It's the hard math that backs up the microscopic smoking gun we just found. So let's just lay it all out on the table. We've got high sodium in the urine, we've got those muddy brown casts, the dead cells under the microscope, and our FeNA is over 1%. I mean, come on, all the evidence is pointing in one and only one direction. So, detective, what's the final call? The verdict is N. It's acute tubular necrosis. This isn't just a flow problem to the kidney's own machinery is damaged. We have our diagnosis. Case cracked. But hold on. just because we've cracked the case doesn't mean our job is done, not by a long shot. Now comes the really important part, executing the treatment plan. How do we manage this whole situation and help our patient recover? First things first, it's all about fluids. And this is a total tightrope walk. You have to get the balance just right. We call this euvolemia. Give too little fluid and the kidney injury gets worse. Give too much and you can overload the heart and lungs. It is an incredibly delicate balance.
And of course, the treatment has to match the cause of the crime, right? So if this was all kicked off by a scleroderma crisis, you hit it with ACE inhibitors. If it was from massive muscle breakdown or rhabdo, you flush the system with lots of IV fluids and bicarbonate. And if that acidosis is getting really bad, you give bicarbonate directly to get the body's pH back to normal.
But that brings up the big question. What if that's not enough? What if the potassium just keeps climbing, where the patient can't breathe because of all the fluid, where those uremic toxins are just overwhelming the system? What's our last resort?
That's when we bring out the big guns, dialysis. And there's a super handy way to remember when it's time to pull the trigger. Just remember the vowels, A, E, I, O, U. A for severe acidosis, E for out-of-control electrolytes like that high potassium, I for certain intoxications, O for fluid overload that just won't budge, and U for uremia that's causing major symptoms like that scary pericarditis. You hit any one of those, and it's time for dialysis.
So there you have it. We went from asking about a simple blockage all the way to finding a microscopic smoking gun in the urine. It just goes to show you, diagnosing acute kidney injury is pure clinical detective work. It's a puzzle with incredibly high stakes. It really makes you wonder, doesn't it? What other medical mysteries are solved using this exact same kind of methodical, clue-by-clue investigation?